Alright, so this is chapter 42. As I mentioned in your announcement, 41, you guys can just go over and kind of get the overview of the eyes and ears, pretty much like the nervous system. So here we're going to kind of just go more into disorders. So this is caring for clients with eye disorders, and then we'll get into ear disorders. Again, I basically want you guys to kind of just focus on administration, probably of like ophthalmic medications, because you might be giving eye drops. We'll talk about like glaucoma, macular degeneration, and things that kind of just happen with age, infectious and inflammatory eye disorders, retinal detachment, that kind of stuff, and basically just how to kind of do a thorough eye exam, or what you're basically looking out for, okay? All right. So these are just some vocabulary. So these are different words that you might hear. Normal vision, myopia is going to be nearsightedness, hyperopia, farsightedness, presbyopia. You get this as associated with aging and difficulty with near vision. That's why people have like readers or whatever. And astigmatism, which I have, thankfully, is visual distortion caused by irregular shaped cone, or cornea, excuse me. So basically, yeah, these are just the more common eye disorders that you can get. Here, it kind of goes through them a little bit more. We just talked about like exactly what they are, and you can read this over here. So normally, this is kind of how the light enters the eye. And then right here is kind of where you process it. This is kind of what's going on in each scenario and how it kind of gets a little distorted. But again, you guys don't need to focus on this. We use like Snellen charts. Those are those charts that you cover one eye and you ask the patient to read, you know, the letters and stuff like that. I thought there was going to be one on... I guess not. Okay, that's fine. So let's go back here. Sorry, guys, I'm all over the place. You guys are used to that, though, right? Okay. All right. So refractive disorders, like I said, we just kind of talked about that. They can be inherited. You'll see people that like the long line of their family wears glasses. It could also be surgical treatment results. Also just age changes, right? We talked about degenerative changes. Usually assessment findings are going to be any change to their vision. So blurred vision, recurrent headaches. I remember when I was getting diagnosed with my astigmatism, I have really, really bad headaches and trouble focusing. So even, and now definitely without contacts or glasses, it's pretty blurry, but I'll get insane headaches right away because my eye is like continuously trying to focus. We talked about diagnostic tests. So again, those charts that we use to cover the eye and kind of have the patient read out loud. And then there's also scopes. I'm sure if you've ever been to the eye doctor or in maybe just for your annual exams, the doctor sometimes will look into your eyes. So usually if you have anything going on like this, eyeglasses or contacts, we now know there's like LASIK and other types of procedures that you can get done. But the less invasive ones are going to be your glasses, right? All right. So blindness and visual impairment. This kind of just goes over what is considered visual impairment and some causes. Like I said, you could be born with it. You can have an injury. You can have some type of nerve damage or a tumor pressing up on that like octave nerve. And usually corrective lenses, or they even do rehab. I don't know if you guys have seen before, like someone has like a lazy eye or something, and they'll put a patch on one eye and try to get that like strength in the other one. So that really just depends. The stuff really you're not going to be too far into unless you are, in a clinic, an eye clinic, that kind of stuff. These are just some nursing interventions. If you work with a client that is blind, introduce yourself each time you enter the room. We should kind of be doing that in general, but again, just making sure that they know you're in there. Call the client by name during group conversations, because again, the client can't visually see. When we talk to people, we usually make eye contact or, pick up body language cues. Speak before touching the client. Again, you don't want to startle them. And then also tell the client when you're leaving the room. Eye trauma. So this is literally any type of trauma that can happen to the eye. Could be something like you get something in your eye, weather changes, injury, anything like that. So usually there's pain associated with it. Some people, if they get like sand or something in their eye, there's like a gritty feeling every time they blink. Tearing, blurred vision, asymmetric eyes, diplopia, edema, bleeding, and purulent drainage. In the ER, we usually take eye things pretty seriously, depending on kind of the mechanism of injury. Again, a pink eye, a goopy eye, not as worried about. But any type of injury, like we've had kids come in with fireworks, got lit, and some of the stuff ended up in their eye, chemical stuff, any type of injury that's going to possibly or potentially cause, blindness or whatever, we take very seriously. Remember when I always talk about triaging those patients, those are going to be our like immediate attention patients. A lot of people get corneal abrasions. So this dye right here, diagnostic findings, we call it the monster eye and the PZD. So basically what we'll do sometimes, corneal abrasions are not, you can't really see them just like naked eye. So what we'll do is we'll put this dye kind of in their eye, and then we'll get a light and you can actually see the scratches on their eye. But it turns their eye kind of like a neon greenish. So yeah, they look kind of crazy. But yeah, it's very nice to diagnose with that. And we'll usually just give them, some ointment to try to correct that. But also x-ray, CT scans can kind of figure out if there's more involvement, deeper within the eye. Medical and surgical management. Like I said, we already kind of went over some of these. And then hospitalization or surgical care is really going to depend on the severity. So you guys were supposed to do this in lab, but I think you've already done some of these, or I don't know. It's kind of a mess. But here again are the steps. Instilling ophthalmic medications. We want to wash our hands. Wipe the lids and lashes. Pull tissue near the cheek downward. Tilt the head back. Do not allow the tip of the container to touch the eye. Again, that's just for infection. So hold it above. Instill the ordered medications. Again, it's going to tell you 1 drop, 2 drop, left or right, maybe both. Close eye. Wipe away excessive medication on the skin. If there's a dressing, you reapply it, and then let the patient know not to rub their eyes. Conjunctivitis. See this all the time. So this is basically pink eye, right? So it could be bacterial, viral, or another type of infection. It's usually very easily transmitted, and it could potentially lead to blindness if severe, chronic, or untreated. So usually it's that red tearing eye. Sometimes people get burning, itching, sensitivity to light, gross, goopy kind of drainage, and some people will get enlarged lymph nodes as well. Usually for this one, it is an antibiotic treatment. Again, if it's bacterial, sometimes if it's viral, a antiviral medication. Excuse me. We tell people to do warm compresses, irrigation, and then some people will do decongestants and antihistamines to kind of stop that drainage. All right. The next one, so that was more of an infectious disorder. This one's more of an inflammatory eye disorder, uveitis. This one is inflammatory changes. So usually this one's accompanied with specific diseases, or autoimmune disorders. And you can kind of see some of the same symptoms, but blurred vision, photophobia, eye pain, red, congested eye. With this one, the pupil will actually act poorly to light, so you'll see a change in that. To diagnosis, we do a slit lamp examination. You can do angiography, skin tests, lots of different stuff. And then medical management, again, is going to kind of differ. So you can do oral, topical, corticosteroids, analgesics for pain, sunglasses if they're sensitive to that light. All right, so keratitis and corneal ulcers. So usually this is caused by corneal trauma, infectious agents, and even sometimes excessive steroid use. So again, you're seeing these same kind of findings. Diagnostic tests, again, are going to be very similar to what we've talked about. And then some of our medical management is similar as well. All right, here is another infectious and inflammatory eye disorder. This one is caused by hypersecretion, infectious agents, sometimes dandruff with the scalp, or dermatitis. And so usually these are inflamed lid margins. If you ever had like an eyelid that gets kind of puffy and like patchy almost, missing eyelashes, purulent drainage, and frequent blinking. So what they can do sometimes is they'll actually scrape those lid margins and like go under the microscope and examine. And usually with this one, you just get some type of topical antibiotic. And then make sure that you're cleansing your eyes, face, and hair. A sty. So I don't know if any of you have ever had a sty, but they're super uncomfortable and annoying, and they don't look the prettiest. So this one is usually common with the infection of staph into your eye, and it's very common in clients that have diabetes. So if you've ever had a sty, you can actually see it. It almost looks kind of like a pimple. It's tender, swollen, and a red pustule. It takes a while for it to go away, unfortunately. So if you wear like contacts or anything like that, you should be wearing glasses and not touching it. If you also if you wear like monthlies and you get a sty, you should just toss those right away. You don't want to be continuously like wearing a pair of contacts that initially you had an infection with. So warm compresses, topical antibiotics. In severe cases, they'll have to go and like do an IND in it. I've never seen that, but it does happen. Diagnostic findings usually is a culture. You could like, go in and culture to see what type of like bacteria is in there. But usually diagnostic findings is physical exam. You can see a sty. Okay, and then lastly, we're talking about this bimobile gland. So you'll see this a lot with like older adults and dogs. I know this is different, but my little baby had, she was 12, and so she, poor thing, had like a big one in her eye. And at first I thought it might have been a sty, but then we went in and got it diagnosed last year, and she had to get surgery to take it out because it was too big. Basically, it's those sebaceous glands that are like in the eyelid kind of area. They just become blocked, and so it becomes inflamed and large, and enlarged, and it really just blocks. It doesn't like block anything, but if it gets big enough, it can kind of go and scratch that cornea, which you don't want, and it's probably not very comfortable either. So it's not tender, and it's usually in the upper or lower eyelid. And then, like I said, as it matures, it becomes hard and may grow to obscure the pupil or compress cornea. So that's why we don't want them. They do become problematic. Sometimes if they're not affecting the vision or, big enough to scratch that cornea, we really don't do anything. And then, like I said, in severe cases, sometimes they'll go and either completely take it out or drain it. All right. And then the last one, this is kind of more what I'll be testing you on, just because this is something that you'll definitely see with patients a little more often. A lot of those other eye disorders are really going to be more like PCP, urgent care type of things, but you may still have a client that's coming in and reporting those types of things as well. So our age-related macular degeneration. So there's different types. We have dry. This is a gradual onset. And then wet is abrupt onset. So dry, usually you have blurred vision, central vision affected. And then wet, you have visual distortion. Sorry. And your central vision is affected as well. So some of these medical management, you can get some like laser, some photodynamic therapy, diets and vitamins. But again, this is more managed by like your eye doctor, I would say. And then next we're going to get into glaucoma. So basically this is the aqueous fluid imbalance. So you have increased ocular pressure. Remember our eye has a bunch of like aqueous fluid in it. And if you've ever had like a tension headache or congested, like let's say you have super bad allergies and you have a lot of congestion in that area, you'll feel pressure kind of behind your eyes. So it's because that aqueous fluid there's just like more increased pressure. This is different obviously than glaucoma, but similar in that neutralized balance is kind of what I'm trying to say. So you have two different types. You have open angle and acute angle closure. So the difference in assessment findings, you can see open angle, you may experience some eye discomfort, temporary blurred vision, halos, reduced reduced peripheral vision, and then acute angle closure, maybe hard, painful, sightless eyes, some nausea and vomiting, red conjunctiva, and like a steamy cornea, or it feels like it's like blurred kind of, but like steam, like when you look through glass, it has that like steam kind of appearance. So with this, we obviously want to do optical disc visualization. So it's that when they go and look into your eyes, and then there's a lot of other exams. Again, you may have these patients complaining of disorders. This is kind of out of our scope. They would have to go to a ophthalmologist to kind of really delve into this a little bit more. But medical and surgical management, there's lots of medications and surgical things that they can do. Things we don't want them to do, so we don't increase that intraocular pressure, is coughing and vomiting. We know that increases strain, right? And then these are just a couple different medications. Again, I'm not really going to ask too much about that. And then lastly, we'll just do a couple more. We have our cataracts. As you know, in older people, and if you see like older pets, they'll have kind of that like, it looks cloudy in their eyes. So this is normal aging process. You can also be born with it. It could be a lens injury, or it can happen secondary to something else. So you have halos, like I said, difficulty reading, color vision changes, poor night vision, reduced or distorted vision. We'll do that Snellen chart to kind of see where you're at visual-wise, and then we'll do a bunch of different scopes. And so surgical management, they'll go in and actually kind of take away that cloudiness behind the lens. If you've ever seen a video of it, it's actually pretty cool. And then there's also like vision restoration after the fact. So there's different things that you can do for cataracts. Retinal detachment. So again, this is going to be something that you may see if you're like in the ER setting or urgent care. If you ever have any type of eye injury that you even think is close to retinal detachment, please go to the ER. The urgent care is not equipped to deal with this. So basically what can happen is retinal stretching, degenerative changes. I've usually seen it in just like an injury. So signs and symptoms are blind spots, flashes of light, floaters, or complete vision loss. So here again, we'd want to scope. And then there's a lot of surgical management. This one has to be done surgically to fix. But again, retinal detachment, especially as an injury, that's like a very severe thing because it could potentially lead to blindness. And then here you can kind of read about this, but I'm not going to test you on that. So you want to see like the prosthesis kind of steps. All right, that is chapter 42.